Now we will proceed to Dr. Ahmad Taha, inshallah. He will talk about us. He is a professor of anesthesiology in Ain Shams consultants, and he now is a consultant in Health Point in Abu Dhabi. He will talk about us. He is an expert in regional anesthesia. Talk about us in about lower limb surgery. What block should be used or performed? Dr. Ahmad, would you please share your screen, please?
Okay, assalamu alaikum. I'd like to thank everybody about this nice meeting, and inshallah, this presentation you liked, inshallah. Bismillah ar-Rahim. Bismillah ar-Rahim. Mankind, you have been given a knowledge except a little. Inshallah, we'll talk today about the lower limb surgery, which block should be performed. Objective of this presentation, we'll speak about the advantage and disadvantage of lower limb nerve blocks, the lower limb innervation. We will compare about some blocks with similar anesthesia distribution, and I will give some suggestion about peripheral block for each region of the body, of the lower limb, the hip, the knee, the leg, and the ankle. And if someone have a question, I'm happy to answer it, inshallah, at the end. First of all, lower limb surgery isn't spinal enough. The spinal is a very wonderful technique. It's simple, it's single injection, it is rapid onset, it's very successful, it provides some post-operative analgesia. However, in some risky patients, the spinal block the autonomic fibers, and this is very risky in cardiac patients, especially those with fixed cardiac output. Also, blocking autonomic fibers resulting in retention. In patients with coagulopathy, risk of hematoma, although the same guidelines is used in the nerve block, however, in some guidelines, they are less restrictive or less conservative. Some blocks can be used, especially superficial block, it still can be used in patients with coagulopathy. It's thought that spinal bypass the respiratory complication that with general anesthesia. However, if the spinal level is too high, it will affect the respiratory muscle. I'm sorry. It will affect the respiratory muscle and may be risky in patient with pulmonary disorder. Even in healthy patients, spinal may cause backache and post-spinal puncture headache. So in these cases, we prefer to use nerve block as sole anesthetic techniques. Even if the patient is healthy, we can use nerve block as adjuvant to the spinal or general anesthesia. It minimizes the use and consumption of non-steroidal and opioid. As you know, that in diabetic patients, they have impaired kidney function and nephrotic syndrome. Diabetes usually results at the end in nephrotic syndrome. And so non-steroidal should be very cautious in diabetic patients. So to minimize the use of non-steroidal and the opioids, nerve block can play a very good role in this point. However, that does not mean that nerve block is a holy technique with no disadvantages. Nerve block has some disadvantages: the field block, the local anesthetic toxicity, the onset of the block may need time, the ambulation of patient after motor block of the lower limb may be delayed. So inshallah, I will do a presentation regarding how to minimize this complication, inshallah, soon. Let's go to the second step of the lower limb innervation. Unlike the upper limb, the lower limb is supplied by two plexus. So in upper limb, we have the only one plexus with brachial plexus supplying the whole upper limb. And so single injection is enough to achieve anesthesia in most of upper limb surgery. However, this is not the case in the our lower limb surgery. In lower limb, it's supplied by lumbar plexus and the sacral plexus. So in most of time to achieve anesthesia, you need many blocks. Single blocks is very rare to be used as a single anesthetic technique to achieve sole anesthesia. However, we have advantage here in upper lower limb that we don't have the vital structure like in upper limb. So in upper limb, you have the pleura and the lung and the carotid vessel and vertebral artery, and this is an phrenic nerve. So you have spread of local anesthetic to more vital structures. This does not exist in the lower limb. I don't care if the local anesthetic spread to another nerve, it doesn't matter. Yeah, not like if it's spread to the phrenic nerve in the scalene. Also, the vertebral artery in the scalene, the close anatomy between the scalene and the bural and the spinal makes spinal spread. The same in the suprascapular, the close anatomy to the close position to the top of the pleura. And so there's risk structure in the upper limb. Thanks Allah, we don't have this problem in the lower limb. Also, the lower limb is, most of the nerves in the lower limb is superficial, with exception of the proximal sciatic blocks and the lumbar plexus. But all other blocks of the femoral, obturator, cutaneous, as we see yesterday, all of them were superficial. The lower limb supplied by the lumbar plexus and by the sacral plexus. The lumbar plexus, as you see here, it's inside the psoas muscle. This is the psoas muscle. If you dissect the psoas muscle, you find the lumbar plexus inside. Lumbar plexus giving some branches like iliohypogastric, ilioinguinal, genitofemoral, and these are not blocked by lumbar plexus block. Mainly what is blocked by lumbar plexus, obturator, and femoral laterocutaneous, and this branch, which is a lumbosacral nerve. The sacral plexus supply mainly the front of the thigh and the medial compartment. So this is the area supplied by the lumbar plexus, the front of the thigh and the medial compartment, and also both joints. With a small skin area supplied by the saphenous, only skin by the saphenous nerve below the knee. So the main innervation of lumbar is the thigh, front, anterior, and medial thigh, including the muscle, the skin, and the bone. In contrast to the sacral plexus, it's giving many branches, but most of them are small branches innervating the gluteal region and the pelvis, with the big nerve, which is a sciatic nerve. The sciatic nerve is mainly innervating the lower limb below the knee. So it innervates everything below the knee, with exception the small skin areas that's supplied by the saphenous. Above the knee, it's supplying the hamstring, but note that the skin covering the hamstring is supplied by the posterior cutaneous nerve of the thigh, which is not branch of the sciatic. It's a different branch, and it's usually blocked with the sciatic with a more proximal approach. So the more proximally you block the sciatic, the more successful block or spread of local anesthetic to the posterior cutaneous nerve of the thigh. Now we are going to compare between some techniques with similar anesthesia distribution. The first comparison would be between the lumbar plexus and the combined femoral, obturator, and lateral femoral cutaneous blocks. So which one is better? The lumbar plexus single injection compared with these combined techniques usually require 3 punctures, skin puncture, so it's monthly puncture. However, in the other side, the lumbar plexus required a lateral position, and the position or the depth of the lumbar plexus, as you can see here, it's so deep. So while the other 3 nerves, the femoral, the obturator, and laterocutaneous are superficial. So technically in blocking of these nerves are easier in blocks and causes less discomfort to the patient because they are very superficial block. And also they're not requiring nerve stimulation. Nerve stimulation is required in lumbar plexus because because of the depth, you are not sure the position of the tip of the needle. So we confirm the position of the tip by the nerve stimulation. But in the combined techniques, we don't have to use the nerve stimulation. Regarding the anesthesia distribution, both result in good success rate of femoral nerve block and laterocutaneous nerve block. However, the lumbar plexus, in 15% of cases, it may miss the obturator. This not happen when you select the obturator. It's very, very successful block when you do selective obturator block. So we have an spread that is the combined technique have a good advantage far more than the lumbar block. But the lumbar give one advantage in that it blocks the psoas muscle. The psoas muscle is directly innervated from the lumbar plexus, so blocking the femoral will not block the psoas muscle, and it blocks the lumbosacral. These 2 are important for hip surgery, as inshallah I will describe after a few minutes. The onset in the combined block, it's very far, the rapid onset, it's very, very rapid onset compared to the lumbar plexus. Lumbar plexus may take about 20 or even 30 minutes to get a surgical onset of block. However, in the obturator and laterocutaneous, it's usually 5 to 10 minutes. Lastly, and this is the most important, the lumbar plexus is risky than the combined blocks. Combined block has the same risk as every block: infection, hematoma, last, and this issue. But in lumbar plexus, because it's position, this high risk of epidural spread. So it results that you did epidural with hemodynamic instability. The lumbar plexus is deep and it's inside the muscle, so the incidence of hematoma, especially in most of lower limb surgery, patient take anticoagulant after surgery. Before the ultrasound, blind techniques are usually and sometimes associated with the very deep insertion of the needle, and may this result in injury of the abdominal structures. And there's one recorded case that local anesthetic is spread to spinal subarachnoid, because beside the anterior rami or the root of lumbar plexus, there's some covering of meninges. And unfortunately, one patient was unlucky that the anesthetic inject in this area and the spread to spinal and causes death to the patient. So in general, the combined blocks are far safer than the lumbar technique. So in my practice, I preserve lumbar plexus to healthy patient who going for hip surgery. If the patient going to any other surgery, I don't do lumbar. If the patient is unhealthy and he going for hip, I stop doing lumbar plexus. The second comparison here will be between the parasacral and subgluteal sciatic nerve block. Both techniques are proximal techniques to block the sciatic. Subgluteal is far more common and more famous than the parasacral. The nerve position is in the subgluteal is more superficial than that in the parasacral. However, in the subgluteal, as we see yesterday, there is no a good landmark or sonographic landmark. There is no good sonographic landmark, no vascular big vessel related to the nerve in this position, although it's correlated to the inferior hypogastric nerve. However, this is a small nerve and not easily identified by the ultrasound, and it's not related to bone at this position. So subgluteal technique is not easy. It's actually difficult technique, especially if the patient is obese or in old age. In old age, the muscle is infiltrated by fat, and so identification of the nerve here become difficult. In comparison, the parasacral technique, we published a technique in a Canadian journal in 2012. It's contact to the posterior border of ischium, which is very easily identified landmark. Because of this position, you just direct the needle medial to the bone and you will get the sciatic response. Regarding the anesthesia distribution in this block, you block only the sciatic nerve. Sometimes the local anesthetic may spread to the posterior cutaneous nerve of the thigh. But in this block, you block the entire sacral plexus. So you block the posterior cutaneous nerve of the thigh, you block the pudendal, you block every nerve of the sacral plexus. Those and there's some nerves to the sacral coming from sacral plexus, not from sciatic, supplying the hip. So in hip surgery, it is important to do a parasacral block. And more advantage with parasacral, it is rapid onset. It is extremely rapid onset of the block compared with subgluteal. Usually subgluteal takes 30 to 40 minutes to get a surgical dense block compared with 10 to 15 minutes with the parasacral block. So parasacral give you the advantage of easy technique, rapid onset, and it is more successful. It is well known that even with nerve stimulation, the Mansour approach is a nerve stimulation technique to parasacral. And as I showed yesterday, parasacral can be also done by the ultrasound. So it's well known that Mansour approach was the most successful sciatic nerve block technique, because the position of the nerve in the parasacral and the pelvis, so the local anesthetic have no way except to block the nerve. Another comparison between the two blocks with similar distribution, which is the popliteal and the ankle block. As you see, the popliteal is single puncture because the nerve at that point is not bifurcated yet. However, at the ankle, the nerve is bifurcated in 4 nerves. So many punctures are needed to do an ankle block. The anesthesia distribution in the popliteal block, you block everything below the knee except the medial skin aspect that's supplied by saphenous. However, in ankle block, you provide anesthesia just distal to the foot, not to the ankle. So even ankle block does not work for ankle surgery. So if you have ankle scope or ankle surgery or ankle fracture, you cannot use ankle block. Ankle block is giving anesthesia to the distal part of the foot. Walking, some think that is ankle block allow the patients easier block and the patient can ambulate immediately after finishing. This is not true. In popliteal block, the patient will not walk. He cannot do dorsal flexion or plantar flexion. So because of motor muscle block, the same with ankle. The patient doesn't, he can move, do plantar and dorsal flexion, but you block the proprioceptive sensation coming from the sole. And so the patient doesn't feel the ground. So he cannot walk unless this patient is put in the cast. So if the patient is in the cast, he will move the whole limb as a one piece. He will not do dorsiflexion or plantar flexion. So in both of them, the patient will not ambulate properly. The advantage of the ankle block, actually, it is rapid onset. So compared to popliteal block, ankle block is rapid onset. So whenever you have a surgery and you want to perform its distal foot, so I prefer to do an ankle block because it's the onset only. However, in some cases, like in diabetic and abscess or gangrene of the lower limb, the tissue edema will delay the local anesthetic activity. And sometimes it may be risky to go to inject local anesthetic in such infected place. So in this situation, I advise to go, or I think it will be more safe to go, or safer to go to the popliteal block. So now we compare some types of blocks, and we're coming to our target today, which block should be performed. This depends on the regional innervation of this of the area operated and the surgical approach or technique. This is a very important point of the communication between the surgeon and anesthetist regarding what approach and what technique if he will be used, because it will be very completely. For example, if a patient will have a ankle surgery or foot surgery, I will give ankle block. But if the surgeon need the tourniquet, I need to have to give another block, is femoral block, to achieve anesthesia to tourniquet. The same for approach. If the surgeon will do hip surgery, but he'll use anterior approach, the anesthesia will be totally different than if he has the lateral approach, than if he need to do a posterior approach. Similarly, if you want to take a graft, he will take fibular graft or iliac graft. If he will take iliac graft, he will take iliac graft, he will take it the same side or the other side. You should communicate with the surgeon very carefully before starting the case, especially if you don't know this surgeon. If you know the surgeon and know his steps and how he does the surgeries, it's okay. But if you don't know him, you have to discuss with him what he will do precisely. Again, the last point to choose the look, which block he will perform, is your experience and the available equipment. Yani some blocks is easier to be performed by ultrasound. Yani I do lumbar plexus in the bust before ultrasound more than femoral, because I cannot block the lateral cutaneous blindly. But because of the ultrasound, خلاص, I can do it. So no need for lumbar plexus. So the equipment available, your experience with every technique will affect markedly the technique you have to do. In the coming slides, I will suggest some techniques for some surgeries. And inshallah, that's what I prefer to do, the surgeries. These surgeries, most of them will be orthopedic surgery. However, if you have any question at the end, inshallah, I can answer it, inshallah. Let's go to first region, it is the hip. The hip region is supplied by the femoral obturator and innervation from sacral plexus. This is supplying the joint and the entire muscles around the hip joint, except one muscle, which is psoas muscle, which is directly innervated by the lumbar plexus itself. The skin at the lateral part of the hip above the trochanter, it's supplied by subcostal nerve, lateral branch of subcostal nerve, while the skin below is supplied by the lateral cutaneous nerve of the thigh. We have in very common orthopedic surgeries in the hip, which is DHS and total hip and bipolar. This patient is usually done after osteoarthritis, and this after orthopedic in the DHS, the neck, it's intertrochanteric fracture, so the neck, no need to reblate the head, the blood feeding or blood supply to the head is intact. So just correct the fracture here. In these two cases, the patient are maybe healthy, maybe risky. It doesn't matter, depend on the case, it's variant between the case. But unfortunately, in this bipolar, the patient in most of time have a multiple comorbidities. In bipolar, it's usually done after fracture neck of the femur, and the feeding vessel to the head is impaired, so they have to replace the entire head of the femur. The problem that's the associated comorbidity of this patient usually postponed and sometimes is canceled. If the patient is canceled as not fit for anesthesia, I'm sorry to tell you that is mortality rate of this patient is 95% within 3 months. So any patient you say to him, you are not with fracture neck femur, you are not fit for anesthesia, unfortunately, most of them will die within 3 months. Even if you postpone him to try to correct him, this patient, even operated patient, will die, 10% of them will die within 1 year. The mortality rate increasing with and cardiac, and you want a lot of investigation and optimization. So postponing this patient, increasing the mortality rate. However, at the same time, if this patient have a lot of risk and they've received general anesthesia or spinal anesthesia, they also may die. So I think that is anesthesia, complete anesthesia for this patient, especially bipolar hemiarthroplasty, it could be done completely by anesthesia nerve block. So to achieve anesthesia, it can be given lumbar plexus plus sciatic nerve parasecular approach. This will cover the entire surgery except for a small area of the skin above the skin incision above the trochanter, which can be in the lateral approach, which can be compensated by local infiltration or by QL block. The same can be used for the total hip, but the total hip they also change the acetabulum. This is not changed in bipolar. This done in Western country, they have more lifespan and they have a lot of osteoarthritis of the hip. We don't have this in Arab countries. We have, except if the patient has a steroid or something, but most of the time we have osteoarthritis of the knee. However, in the total hip, also the acetabulum is changed, and so they hammer the acetabulum. Take care during hammering the acetabulum, this compresses the sacroiliac joint of both sides, and so the patient may feel some discomfort. So the patient should be deeply sedated during this step. This step takes about 1 or 2 minutes. Here in the DHS, the other limb, some surgeon track the other limb, make traction on the other limb. And so traction will be painful to the patient, to the healthy, non-operated, non-blocked leg. So in this, if the surgeon do this, you have to add either deep sedation or to block the foot of the other non-operated leg. However, most of the time they just put it in this lysotomy position and they not tracted it. But if they do, you have to give deep sedation to the block as well. Now in this video, I show some risky patient. We do it in 15 years ago before the ultrasound. So we depend on the lumbar plexus. As you see in this video,
90 years old. 90 years old. The pulse irregular. About 80. The echo ejection fraction 57. في segmental motion abnormality. aortic stenosis, aortic regurg. حلو. ومايكرو regurg.
We give this patient combined lumbar plexus and sciatic nerve block using the Mansour approach, but no, this is before the ultrasound. This is long time before. In the Mardash hospital. Another patient here with impaired cardiac function. So we do the same lumbar plexus and sciatic using the Mansour approach. And as you see, the surgery is finished, alhamdulillah, very safely and very, alhamdulillah, smoothly. The same technique is done for this patient, 70 years old with severe asthmatic bronchitis and respiratory function is extremely impaired. And the same, we do the same techniques, lumbar plexus and sciatic nerve. This is completely, surgery can done completely by these techniques without even sedation if you don't need sedation. However, we publish after the ultrasound, we test that we can do the same surgery instead of lumbar plexus by femoral, obturator, and lateral cutaneous. We find it's possible and it can be done with one point is difference, that is the psoas muscle is not blocked in the femoral block. And so the patient may feel some discomfort during traction to reduce the head of the femur back to the acetabulum. But this takes about a few seconds and you can supplement the patient during or sedate him before this step. So this as regarding anesthesia, which I recommend sole anesthesia by nerve block to this kind of patient. However, if the patient is healthy, then total hip or DHS, you can use a nerve block as analgesia. You can do lumbar plexus, femoral nerve block. If you add to the femoral nerve, you can add obturator nerve block, you can add sciatic nerve block, and lateral cutaneous nerve block, and sometimes fascial blockade. All these blocks will give a good analgesia to the hip and will minimize the post-operative pain and opioid intake. However, nowadays in Western country, in Arab countries, we have a low pain threshold. So if the patient in pain, he will not walk. So usually we do not ambulate the patient or discharge the patient same day. In some countries, in Western countries, they start to do same day ambulation because they have better, the culture, the patient have more pain tolerance and can tolerate some kind of pain. So they need blocks with no motor blocks. So for this, Bing block is giving a very good advantage to give a good analgesia without motor block. Also, we have a group, our group from friends from Alexandria University. They test the analgesic effect of quadriceps lumborum, and they found it is very effective and can provide a very wonderful analgesia without impairing the motor function. Next, we'll go to the knee, then we'll go back to the thigh. We'll talk first about innervation. The knee is supplied by the 3 nerve, femoral, sciatic, and obturator, and the lateral skin aspect is supplied by the lateral femoral cutaneous nerve. Although the total knee, the incision is the midline, I always give the lateral femoral cutaneous nerve because it doesn't take time and it doesn't take much local anesthetic, and in 30% of patient, it supplies the anterior aspect of the knee as well. So I block it routinely. So for total knee, if I want to do a total knee or ACL under nerve block alone without supplementation or sedation or GA, I give these three techniques, the blocks, the sciatic nerve. As I said, I prefer the parasacral block, plus the femoral and obturator and lateral femoral cutaneous. As you see here, this is a total knee done under nerve block. It's very smooth, as you can see, the surgeon is working and the patient is, it's very smooth surgery and stable hemodynamics. And to me, nerve block can provide a very good, especially if the patient risky, you can do nerve block alone in total knee. No need to adjust it or to supplement it by spinal or GA or even by sedation. In knee arthroscopy, it's the same. It can be the same blocks can be used. However, nerve block is not advantage in the knee arthroscopy because usually the patient is discharged same day. So if the patient is healthy, no need to give nerve block, it's just general anesthesia. And you can add some analgesics, nerve blocks of an analgesic block that have no motor action, motor function. But it's not wise to do nerve block with a long duration of block of the motor function of the quadriceps and the hamstrings, so the patient will not be discharged unless the patient have some serious problem and serious comorbidities. So nerve block can be used even in knee scope. As I said, if your patient is healthy, you can give general anesthesia as well. You can give spinal, it doesn't matter. For analgesia, nerve block can be used for analgesia only, like femoral block. If you add sciatic, the analgesia will be improved. Some people, if you want it for only for analgesia, sciatic block can be blocked as a level of popliteal block, but for analgesia only, not for surgery. And I have some colleagues, they bypass blocking the common pronaal because it's usually the site of problem. And usually if the knee is valgus and he try to correct a valgus knee, this stretches the nerve, causing damage to the nerve. So some colleague doesn't want headache, and so they don't block the common pronaal and they go distally and block only the tibial nerve with selective local anesthetic, small dose of local anesthetic to select block the tibia. And surprisingly, it gives wonderful analgesia after the total knee. But if you want to do the popliteal, you have to do it before the surgery. Usually draping after surgery, you don't have access to do the popliteal. In Western country, in some countries, if they want to charge the patient same day after the TKR, so the analgesic with no motor block, as we described yesterday, they can use adductor canal or IBAC block. In both techniques, they don't have residual motor action, and the patient ambulation and motor function is better. But to be known, this is not the same quality of analgesia like femoral block. although some papers mention this, but in others and in my experience is they are not the same. Femoral block is superior than adductor canal block. We'll go back to the thigh with the famous surgery is above knee amputation. Like the bipolar surgery, above knee amputation, one of the most risky surgeries in the anesthesia. Because in the patient with amputation, he is by default, he's diabetic, and the gangrene make him uncontrolled diabetes. Sometimes he go to keto-diabetic as DKA, diabetic ketoacidosis, and the acid-base disturbance and electrolyte disturbance, and this angiopathy of diabetes, which make the lower limb gangrene. You have the same angiopathy in the kidney function, so the kidney function being impaired. You have the same angiopathy in the heart, so the patient is ischemic heart. So by default, the patient of above or below knee amputation, he's diabetic, in infection and sepsis with disturbance of the acid base, of the electrolyte disturbance, and cardiac and renal also. So I think nerve block can help a lot in this kind of patient. It can be done completely, as I said yesterday, above or below knee amputation completely by nerve block alone. The thigh is also nervated like the knee, as a femoral sciatic obturator and lateral cutaneous nerve of the thigh, with exception that is the posterior aspect of the thigh is supplied by the posterior cutaneous nerve of the thigh. This nerve is supplied by the obturator, by the posterior cutaneous nerve of the thigh, which is branch of the sacral plexus. That's why I prefer to do sacral plexus block in this kind of surgery. So in above and inside surgery, that will be the skin incision the posteriorly. So I do parasacral block because it's more successful block to the posterior cutaneous nerve of the thigh. Now we're going to the leg and ankle region. As we said, the leg and ankle is completely innervated by the sciatic. Sciatic supply everything, the skin, the muscle, the bone, everything, except very small skin area in the medial aspect, which is supplied by the saphenous nerve. So for below ankle surgery, popliteal block is enough, more than enough. With exception if the surgeon will use tourniquet, in this point, you have to anesthetize the tourniquet site, which is by femoral block or heavy sedation if the patient is cooperative. If the patient is not cooperative, give the femoral block if you want it for anesthesia. For analgesia, خلاص, general anesthesia is enough. So if you give popliteal plus general anesthesia, patient will not feel no pain at all. But if no general anesthesia and no sedation, so you, the patient will have the surgeon request a tourniquet, so femoral block will be added. If the surgeon will not use tourniquet, but the surgery itself in the medial aspect of the leg, so incision will be at the distribution of saphenous, so you add adductor canal. Note that is if you don't do femoral block, no need for the adductor canal block because it's covering all innervation of the adductor canal. If the surgery is not in the medial site and the surgeon doesn't need a tourniquet, so nerve block, popliteal nerve block is more than enough. And that's what we use in the below knee amputation. We give either popliteal plus femoral for the saphenous block or popliteal plus adductor canal. And the same for ankle surgery because it's done under the tourniquet, under ankle scope. So we give popliteal and femoral block. Then we'll go to the foot and distal foot surgery. As you can see, here this is the cross-section diagrammatic cross-section of the foot. This is posteriorly the tendo Achilles, and this is medial malleoli, and this is lateral malleoli. The foot is supplied by 3 superficial nerves started by S letter, with sural, superficial peroneal, and saphenous nerve, and 2 deep nerves, which is deep peroneal nerve and posterior tibial nerve. The posterior tibial nerve related to the posterior tibial artery, and the deep peroneal related to the dorsalis pedis artery. These 5 nerves supplying the distal foot. These 3 nerves, the deep peroneal and the posterior tibial and the superficial peroneal, should be blocked for any foot surgery. If the surgery in the medial aspect, you add the saphenous. If the surgery in lateral aspect, you add the sural. But if the surgeon will have a tourniquet, you have to give again femoral nerve block. If no tourniquet and the surgery in the middle here, not medial, not lateral, so these 3 blocks, posterior tibial and deep peroneal and superficial peroneal is enough. No need for saphenous, no need for sural. In this video, we'll show a surgery done in the foot. Then under tourniquet, the patient received ankle block for the surgery site, but because of tourniquet, we add femoral nerve block. So So to summarize what I've said, in the hip region, the bipolar and total hip and the DHS, you can give the lumbar plexus plus sciatic nerve block. If the patient is risky, femoral, obturator, and lateral cutaneous can replace the lumbar plexus. Take care in the lateral incision because of the bipolar, spread the incision above the equator trochanter. You can give QL or local infiltration. In total hip arthroplasty, you need deep sedation during hammering. And in DHS, take care about if the other leg, contralateral leg, is retracted. This for anesthesia. In the thigh and the knee surgeries, femoral, obturator, and lateral cutaneous nerve plus sciatic, the parasacral approach can provide anesthesia for all this region. In the knee scope, because the patient may be needed to be discharged same day, it's better avoid nerve block as a sole technique. In the leg and ankle, popliteal block, if you need tourniquet, so add femoral block. If the surgery in the medial aspect, you add adductor canal. In the distal foot, same, you give the ankle block. If the tourniquet you have to add the nerve block. For analgesia, in the whole this region, femoral block is the main analgesic technique. You can add obturator or sciatic or lateral femoral cutaneous nerve. This will improve the analgesia. If you don't need motor block in the hip, you can give the QL or the Bing block. In the knee, you can give adductor canal, IBAC. Lea technique is done by surgeon. So the surgeon during the TKR may prepare some local anesthetic, very diluted local anesthetic, 150 ml of very diluted local anesthetic, and they infiltrated everywhere. This is called local infiltration anesthesia or Lea technique. And in knee scope, we may inject intra-articular local anesthetic with morphine and ketorolac inside the joint. But as I said to you yesterday, putting catheter and maintaining infusion of this may risk to damage the cartilage. Analgesia for the foot and below the knee, popliteal block will avoid analgesia, but still it will block the dorsiflexion, motorflexion, and also ankle block can provide analgesia if you want to add general anesthesia. Thank you so much. And any question?
Prof Taha.
دكتور عصام.
Thank you so much.
طيب في البث
Many thanks to Dr. Ahmad for such a brief, concise, valuable lecture. In fact,
I have one question only. I have one question, if you please, Dr. Khalda, please. Prof Taha, very primitive question. What are the doses of analgesia you are using and the anesthesia for the local anesthetics, and what do you prefer? What do you prefer in using the drugs, ropivacaine or bupivacaine?
Look, Dr. Assam, we have in our hospital inhibit using bupivacaine at all, especially the R isomer, because the risk of cardiac toxicity and the last. So it's not exist in our hospital. So only either L-bupivacaine or ropivacaine. We have a good experience with ropivacaine and we like it, so we use mainly ropivacaine. Ropivacaine, we use it for anesthesia for all nerves 0.3, and it may be using less dose if you have enough time to achieve a good, if you're for onset. Yani 0.3 give you good onset time. If you use 0.2, it will give you anesthesia also, but it's lead longer time of onset. And I published one study in British Journal using and one in another one in anesthesia. That's I block the femoral nerve using 0.16% of ropivacaine. But this needs a very long time for onset. So to be more clinical and more practical, we use 0.3 to achieve anesthesia in any nerve all over the body. With exception of the sciatic, we use a higher concentration, 0.5. For analgesia, surprisingly, 0.1 is enough. 0.1.
How many cc?
For femoral, I use 20. For obturator, I use 10. For lateral cutaneous, I use 5. For the sciatic, any approach, I use 20. For the adductor canal, 20. And for ankle block, each nerve about 4 or 5 ml. For lumbar plexus, I use 30. So, but the same concentration as I told you, all of them 0.3 with exception of sciatic because it's thick nerve, and to infusion or diffusion of local anesthetic molecule inside the nerve need time, and it's related to the concentration. So in sciatic we use 0.5. In others, we use 0.3. In most of patients, we use a total dose of 200 milligram ropivacaine, which is acceptable to the patient above 70 kilogram. If the patient is less than this, we can minimize the local anesthetic volume also. However,
do you prefer to add any adjuvant like magnesium?
Yes, in the past we add adrenaline as the IV marker. However, we don't do this nowadays. I add the dexamethasone, although this is off-label dose, off-label route, preneurally. It is prolong the block dramatically, but at the same time it prolongs the motor block. So if the surgeon doesn't have a problem with 24-hour motor block, I add dexamethasone and give 24 hours of motor and sensory block. It's very wonderful.
Any value for sodium bicarb? Any value?
Look, in some in the past I read that can help in accelerating the onset, but already we have in our setup in my hospital, we have a complete room for nerve block. We bring the patient early, we do our blocks, and we have 24 time of the onset block, so I'm not in hurry like Spinal. So we'll not add some medications that we are not sure that is not risky with no reason. Yeah. So we do the blocks in this induction room, and so we have the time to assess and re-block the patient if needed. And we confirm because if you want to do anesthesia, and you have to confirm that every block you did is successful. So you need time. And this is a point in our hospital. We bring the patient 1 hour before surgery. I do my blocks, I'm happy. Then we shift the patient to the block room. So I didn't do adding sodium bicarb before.
Most of the time, and the most common procedure is amputation in deteriorating diabetic patient. Is it working the block in, for example, amputation of the lower of the big toes or amputation in the ankle?
Yes. It works, and it works very nice. And I did one case here in Abu Dhabi amputation, and I did many in Ain Shams amputation under nerve block. Nerve block you can do any surgery in lower limb with no exception. With no exception. If the below knee amputation, it's simply you give popliteal plus femoral. If the above knee amputation, you give popliteal, femoral, sciatic, parasacral, and obturator and lateral cutaneous. With ultrasound, it's a piece of cake. It does not take 5 minutes. The onset after 15 minutes, and that's it.
In case of ischemia or infection, that's what I mean.
It works. Look, Dr. Essam, the insertion of the needle is far from the infection point. Yani if you have a below knee or above knee amputation, you block the femoral at the inguinal region. You block the obturator at the inguinal region. It's far from distant from the infected area. And the parasacral, you do it at the level of the pelvis. So this is about 30 or 20 centimeters above the infection. The same for popliteal. If you do mid-leg block or mid-leg amputation, the popliteal, you do it about 7 centimeters above the crease of the popliteal crease. So still far from the amputated part and from infection. But as you said, in the foot, it may be close. That's why I said in the comparison, if the infection is close to the foot, to the injection point, you can bypass the ankle and go more cephalic to the popliteal block. So it will provide energy and a good anesthesia, and it's very successful really. But the problem with popliteal, it's delayed onset. So you can add some lidocaine on the local with naropen or ropivacaine to achieve a faster onset of the block.
Thank you.
Thank you very much for your lecture, informative. I'm just asking, some people still mixing local anesthesia up till now as clinicians think that it works fast and it can continue for a long time, like mixing lidocaine with bupivacaine or levobupivacaine or ropivacaine. What's your opinion about that?
Look, in mixing local anesthetic, it will not prolong the block. because lidocaine is shorter than bupivacaine. So it's no way it will belong the local anesthetic block. But the point is about the onset. Mixing local anesthetic really faster the onset. So if you have a problem, but it will fast it how much? Yani if the block of the femoral with ropivacaine is 10 minutes or 15 minutes, you want to fast it to be what? To be 5 minutes? And as I said to you, you have a 1 hour preparation and equation. If you are really in hurry and you want to achieve a very rapid onset, you can do this. But take care that adding local anesthetic may increase the risk of toxicity. So you have to calculate both toxic dose of both. You are using 2 medication, each one of them have toxicity by itself. So if you are in hurry and extremely hurry that you want the block is not working within 10 minutes, you want it within 5 minutes, it's okay. Add the local anesthetic, but be cautious about the toxicity. But if you are not in hurry, no need. Yani I don't think there's a need to mix local anesthetic, ropivacaine, except as I said, if you want to prolong it by dexamethasone, and again, this off-label use. Dexamethasone still can, by the way, prolong the block if you given IV. And some studies in British Journal showed that is even IV prolong the local anesthetic duration. The mechanism is not well understood, but it is fine as observation.
Thank you, Doctor.
Yeah.
We have many questions from the attendees. Please, Dr. Ahmad, Dr. Talat Al-Abd asked about the hip surgery. Which is better to be applied, the suprainguinal fascia iliaca compartment versus a lumbar plexus block with a parasacral sciatic nerve block? Which is better to be
for surgery?
For surgery.
And anesthesia, fascia iliaca will never block the obturator nerve. So if it's for analgesia, it can be used. For anesthesia, no way it can be used. It cannot achieve anesthesia in the distribution of the obturator nerve. And the obturator and the accessory obturator, both of them supply the hip. So no way fascia iliaca will provide anesthesia to the hip. But if you are going for analgesia, it can be used because it will block the femoral nerve and lateral cutaneous nerve. But for anesthesia, it will not. And of course, you have to add the sciatic with will
be the main issue. Dr. Adil Milad asked about the nerve catheter in analgesia regarding hip or knee arthroplasty.
Yes, unfortunately, nowadays the fashion or the era nowadays to discharge patient as early as possible. So even blocks with normal duration of 6 hours or 12 hours, some surgeon doesn't like it nowadays. They want to ambulate the patient same days. So actually putting catheter is not, actually our catheter in my department is expired because we don't have a chance because the surgeon wants to ambulate the patient. If I put the catheter, the patient will be not ambulated for 3 or 4 days. By the way, there's some new molecule of bupivacaine called liposomal bupivacaine. It works for 4 days, but it's extremely expensive. It's maybe 1,000 dirham, about $200 per ampule. So it is used for non-motor block. If you are giving abdominal block like TAB or quadris lumborum, you can use this very long. It works for 4 days. So you can give a very wonderful analgesia, but for lower limb, nowadays prolonging the block is not an advantage. Actually, it's a disadvantage. So it's no longer use the catheter. In the past, even in my web site in the YouTube, I described many techniques of the catheter, but as I said, nowadays we don't use it because you want to minimize the motor block, especially in lower limb, because the patient cannot ambulate.
Can you use opioids or something instead of the?
No opioids. It's not like in peripheral nerve, we don't have receptor for opioid like in centroaxial. In centroaxial and spinal and epidural, there's mu receptor for opioid. And so opioid can improve the density of block and may prolong the block if you add fentanyl or morphine to the epidural, but it's not existent in the lower limb. So no use at all to add any opioid at all. No receptor.
Dr. Radwan, Essam asked about the neurological deficit. If the patient has a neurological deficit for medical legality, can I give a block for such a patient, even if there is a deficit?
Look, if you are afraid from medical legal and the patient is healthy, don't do block. Keep yourself and safe. But if the patient have a cardiac problem and respiratory problem and nerve block is life-saving to him, in this case, I will discuss with him very carefully about the risk of nerve block. And I inform him that nerve block will not change his condition, and if happen it worst, and I'll take a very clear consent from him. Yeah, for example, if this patient have a myocardial infarction and very low ischemic ejection fraction and very bad expiratory, so and most of diabetic have neuropathy. So the patient with diabetes has ischemic heart and impaired kidney and has neuropathy. In this case, I'll tell him you have risk, blah blah blah, and you accept the risk. If you accept, it's okay, I'll do. If he doesn't accept, I'll not do. Also, if the surgeon is risky, I'll not do nerve block. Yani, can you imagine, once I work with a surgeon, a patient, he have obstructed labor and the baby died because of obstetric reason, and he told the patient that is because of epidural.
Oh, yes.
So can you imagine you will help this patient, the surgeon, again with epidural? No way. So if the patient is risky, no way, no way. So if the patient, even if some doctor with no experience, so I'm afraid of him. So I'm afraid of the surgeon that he may injure the nerve during working. I'll not do the nerve block except if the patient has a contraindication for general or spinal. So in this situation, I'll discuss with him very carefully. Some surgery by itself causes nerve injury. Yani valgus correction in the total knee, they are stretching the nerve, and the common peroneal injury is common after total knee. So if the patient have valgus, and I see in the X-ray that he has valgus, I'll try to avoid the sciatic, and I'll try to do nerve block as a sole anesthesia technique. And unless, as I said, the patient had another contraindication. I don't want him.
Okay, Dr. Radwan, Essam also asked about the better for short block without motor affection, and maybe Vicane or lidocaine to be used for such a block.
I don't have experience with Vicane. It's not available in my hospital. I cannot tell. Both of them is intermediate action, but I cannot tell. Even lidocaine in femoral block may stay for about 6 hours. So femoral block with femoral block with lidocaine may take 6 hours. So it's very long time with even lidocaine. I don't know with Vicane. I never use it as a nerve block.
She said a statement I don't agree with, but I have to see it. She said that the lidocaine more toxic in peripheral nerve, but less cardiac toxicity, has less cardiac toxicity. Is that right?
Compared with what?
She said that the lidocaine is more toxic in peripheral nerve, but less toxic on the has less cardiac toxicity.
No, this is not true. Lidocaine is used very widely in plastic surgery and in many surgeries. If you don't pass the toxic dose, and even if injected IV, in some doctors use lidocaine injection IV for pain and chronic pain even. So if you use it in the safe dose, it is not toxic. But the point, if it reaches the circulation with beyond the threshold, it does not affect the cardiac, it's more affects the CNS. Similarly, the naropin, it is less cardiac toxic than 1/7 the cardiac toxicity than that of bupivacaine. But lidocaine is a safe drug. But the point is, if you want to provide post-op analgesia, I'll not use lidocaine.
By the way, Dr. Ahmad,
if she wants really think about short local anesthetic, it's chloroprocaine. Chloroprocaine, the patient can be discharged within 2 hours, but expensive. Okay. But it's very short, very, very short. Yani you use it as a spinal. You have to be the patient ready for surgery immediately, because if you delay the surgery, like what we do with naropin, the block will be recovered and patient block will be finished before surgery. So if she needs a really short acting and rapid acting to discharge the patient, chloroprocaine is the best. And nowadays they remove the preservative, so it's no longer toxic to the nerves.
By the way, Dr. Ahmad, you mentioned intravenous local anesthetics. Are you still using Pierce blocks?
No, at all. Look, Dr. Essam, the comparison between safety is beyond. Yani you have risk of toxicity with intravenous when malfunctioning the tourniquet, to insert an IV line, and to have special equipment, and there is no post-op analgesia. And if the surgeon have some surprise inside and he want to prolong the surgery, so nerve block can do all of this. And upper limb, block, if it's prolonged for some times, what is the problem? The patient will go home, he will do all activities with the other limb. So I no longer do this since 20 years, maybe.
Dr. Iman Shulbagi asked about the use of the nerve stimulator for lower limb blocks.
Yes.
What is the current required to be used and how to decrease it to the elicited response?
Nerve block is very successful technique, and I like it so much. I work with nerve block for about 10 years. It's very successful, and you can achieve the same quality. But the point is the discomfort to find the nerve is more with nerve stimulation, and the time you try to find the nerve or tracing the nerve. Also, a new techniques cannot be done by the nerve stimulation. However, if you have nerve stimulation, you can do any of the above block, the block I mentioned, lumbar plexus, sciatic, femoral, obturator, but lateral canals you cannot do it because it has no motor fiber. Regarding the currents you can use, it was mentioned in studies that if you are current between 0.2 milliampere and 0.5 milliampere, if you can elicit twitches with the current between this 0.2 and above 0.2 and less than 0.5, you are in a safe place or close to the nerve. If you use current 0.5, more than 0.5 milliamperes, that means that you are far from the nerve. So your block will not be that successful. I'm sorry. And if you elicit nerve twitches with the current with less than 0.2 milliampere, that means that's intraneural. So this is as regarding the current in all nerve, exception, the only exception is the lumbar plexus. Lumbar plexus, if you get the response between 0.5 and 1 milliampere, this is a good position of the nerve. Also, for one hint, if you are doing sciatic with nerve stimulation, you adjust the tip of the needle to twitch the tibial nerve twitches, which is plantar flexion, not dorsal flexion. The success rate of the dorsal flexion is less than 57%. So half of the cases with, with the common peroneal, which is the dorsal flexion, will be failed. So if you're doing sciatic with nerve stimulation, you try to elicit tibial response, which is plantar flexion. As I said, between 0.2 and 0.5 for all nerve blocks all over the body, with exception the lumbar plexus between 0.5 and 1 milliampere.
There is one question, Dr. Ahmad. How to avoid intraneural injection, and did you see any bad scenario for intraneural injection as a permanent injury?
Alhamdulillah, I didn't. Alhamdulillah, I didn't. But the point is how to be 100% sure that you not inject intraneural. This not exist like intravenous. You cannot avoid it 100%. This is non-avoidable complication. However, we minimize the risk. First, by the ultrasound, you see the tip of the needle. So you have to be carefully seeing where is the tip of the needle. Second, if you use nerve stimulation, try to not be elicit nerve electricity or twitches less than 0.2. Third, we use the same syringe brand and 20 ml syringe. So the technician who inject to me, if he find any resistance to injection and he build experience with this type of syringe, which resistance facing him, if you find unacceptable, unusual resistance, he tell me you are intraneural, change your position. So unexplained risk, high resistance. Also, if the patient is awake, paresthesia may help. However, it's not 100% sure. Paresthesia have false positive and false negative. But still, you have to be cautious. If the patient is in pain, you have to ensure what is going on. If the pain radiating to the nerve distribution, so you are intraneural. But if the patient, you are doing for example, sciatic, and the pain in the gluteal region, so mostly due to the needle. But if the pain like electricity going down to the foot, so this is intraneural. Lastly, in Nysura, they make a pressure gauge equipment that is connected to the syringe. If you bypass certain limits, it will go up. If you go to the red zones, so you mean intraneural. However, as I said, there is no 100% technique sure that's intraneural. Good news that subhanallah, Allah subhanahu wa ta'ala make our nerves can correct a lot of our mistakes. So even they find in some studies that is intraneural injection, the nerves can correct itself. Unless you are extremely unlucky, increased pressure inside the nerve will make ischemia of the vessel feeding the nerve inside, and the nerve injury will happen. However, alhamdulillah, I've never seen this, because I said to you, as I mentioned, I make these precautions in every patient with no exception. One patient have a problem like this with the technician write in his record that you don't do this step, I'll lose my job and the patient will lose a functioning limb. For what? No need.
Alhamdulillah.
Alhamdulillah.
Excellent.
Thank you, Dr.
I think time now to close the session.
Sorry for the disconnection. There's some questions for Dr. Abdul Latif left. I think we have to ask him, please, if you have time.
Yeah, we still have one more question if you.
Dr. Essam asked about with the using of 3 filters in the circuit to increase the resistance. How can we overcome such problem?
No, it doesn't increase the resistance.
Does not increase the resistance.
No. Filters are being manufactured not to be associated with any increase in the resistance.
Dr. Nagi Mustafa asked about the PCR, if it is recommended for the regional anesthesia to be done before and will be used as a guideline.
You mean patient?
The patient with regional.
GA versus regional for PCR preoperative. There is no difference. I mean, if the patient you decide to give, it doesn't matter to eliminate PCR because the patient is having regional. No, this is not justification.
Dr. Muhammad Ahmed asked about the obese patients, how to calculate the dose of rocuronium according to the total body weight or the ideal body weight.
Ideal body weight. Because our neuromuscular blockers are not lipid soluble. All of them are water soluble, and the volume distribution is the volume of the plasma or an intramuscular. They don't diffuse to the lipids, unlike the barbiturates, for example. All neuromuscular blockers are water soluble and they have low volume distribution. And that's why you can give it on the ideal body weight.
Dr. Sameh Zaki asked about a very critical question. Actually, if the patient with a deteriorating patient or rapidly urgent intubation in cardiac arrest or in ER, something like that, what essential required BBE to be going on? We select something or we have to
BBE.
Full BBE. He asked for the time. It will be time consuming to put all BBE before resuscitation.
He has to put BBE.